Um, Dr. Frid is a developmental pediatrician and the medical director of the Thames Valley Children's Center. Dr. Frid completed her MD degree at the Queen's University and her pediatric residency training at McMaster. After residency, she completed a fellowship in developmental pediatrics at McMaster University. In 1988, she was appointed to the Department of Pediatrics with Queen's University at the rank of lecturer, and 2 years later, she was promoted to the rank of assistant professor. In 1999, she became an assistant professor at Western University, and in 2003, she became a medical director at the Thames Valley Children's Center. Her talk today is entitled Assessment of the Child with Suspected Developmental Delay. Thank you.
If I can, Greg, just before you start, so instead of what we'll do is we'll let Pam do her talk, and then we will have time for question and answer. And I prefer people use the raise hand function. That way people can ask their questions orally or verbally, and we can then sort of, if that leads to some potentially discussion of things as well. So we'll just keep questions till the end of Pam's talk.
Great.
Okay, thank you. I'm just trying to get my slides up. For some reason, it is not working. So while I work on, there we go. So thank you very much for that introduction. And what I'm planning to say today is really trying to give you lots of practical tips on how to assess a child that presents in your office with developmental delay. And I've tried to concentrate on tips and tools that you can use to do the assessments that you can find for free or can be downloaded from the internet very easily. So if you have any questions about where to find them, I've tried to put the links for anything that I mentioned in the presentation so that you can see them. And I understand that this will be posted later, so you'll have access to that as well. Okay, now that I've got it up, I've got to figure out how to move on to the next slide. You think I've never done this before?
So Pam, I think if you actually at the bottom of your screen where it's got like the slideshow thing.
Yep. I just went to that.
Yep. And now you just have to use up and down, I think.
Yep. There it goes. Okay. So there's the faculty presenter disclosure that Greg gave to you before. So my objectives for today, and I will go through these when I do it in each section, I'll outline the objective again. First, I'm going to talk about the screening tools for a child that you suspect of having developmental delay. Then the red flags that you might find as you approach children, or that other people who work with the children may have noted and sent them to you. And finally, talk about how to investigate the delays in children. So if we're going to understand the concept of trying to deal with children presenting with developmental delay, we actually have to think about this in 3 stages. The first is surveillance, and that's just the process of recognizing children who are at risk for delay. Then for those that are at risk, then we screen them, and the best way to screen is using standardized tools. And the third step is the actual formal evaluation that comes beyond screening. So screening is identifying those children who present with difficulties, but evaluation helps us to actually figure out what the cause is and what we need to do about it. So surveillance is something that many of you do all the time. And it starts off by listening to what the parents have brought their concern to be, and then they bring that to you. Then you have to document that, of course. One of the really important steps that we need to remember to take time to do is to actually make observations of the child. And we do that by looking at them, watching them play, trying to have a conversation with them, trying to play with them. And that gives lots of information. And then, of course, we have to maintain and document all of this. Screening is using tools. It's not just asking a few questions, but it's actually using specific standardized tools. And if I was to give this talk when I've given it before, we talked about how good screening is, and we all learned those milestone lists when we were in school that we should look for. But since then, we've learned that in fact you are more accurate in doing your developmental assessment if you actually use screening tools. And this was demonstrated in a very lovely way by the group in Edmonton. They presented a lovely paper on that, which I've referenced here. So that's why the emphasis has moved from just asking questions to actually using tools, because we are more accurate. We're more accurate both at finding children with delay, and we're also more accurate in putting aside what might be one small concern about development and saying, no, the child is doing fine. So if you're going to use screening tools, however, though, you have to make sure you use the right one. So you have to be aware of what age group the tool was developed for use in, and you need to use it just within that age group. Don't use it outside the range that the tool was developed for. So if you're seeing a child who's 4, don't use a tool for someone that's only been standardized up to the age of 3. It's also important to know that you will get better results if you are able to use a tool in the language of the people that you're using it with. So many of the tools that we use are ones that parents are asked to answer questions, but you'll actually get more reliable results if the parents are using the tool in their own language. And many of the tools have been translated into multiple languages. One tool I use sometimes has been translated into 90 different languages. So if you are using one of these tools, check the website and use the best translation that you can get. Okay, now moving on from screening, evaluation. And if we think about the 3 levels of identifying children with delay, normally we think of surveillance being done by primary care providers, screening can be done by primary care providers, or sometimes moving up the level. So in the case of children, that would be with pediatricians. And evaluation is a more standardized and formalized process than screening, and it is done by pediatricians or sometimes by subspecialists like myself, a developmental pediatrician. But it's important to move on to evaluation and be very deliberate about it, because once you evaluate and come up with a diagnosis, then you know what the prognosis is, which is a question that many parents ask. It allows you to initiate therapy, and it also allows us to answer the question about what is the cause, which everybody always wants to know. So the Canadian Paediatrics Society in 2011 published a paper where they talked about the importance of developmental surveillance. And from that came the concept of what we should do for surveillance. And they outlined it all very nicely, and I put some of that here on the slide. But even more important is that it led to the ongoing development of some evidence-based screening tools. And there are 2 that are available in Canada, both free, and they are endorsed by the College of Family Physicians of Canada and by the Canadian Paediatrics Society, and also by the Dietitians of Canada, because they've now included a lot of information about healthy nutrition. The one that we're probably all familiar with is the Work Baby Record. And this gets updated periodically and was last updated in the fall of 2020. So there is a new version. If you haven't got it, I suggest going to the website and downloading it. And be careful that you pick out the Ontario version if you're practicing on Ontario, because each one of the Work Baby Records is individualized for province, because there are different immunization schedules in different provinces. So you want to make sure that you're using the correct one. Each version of the Work Baby Record is updated with the most reliable evidence-based information to help with your surveillance and screening. So it's really nice that this is done for us and we don't have to go looking for the updated information. What less people are familiar with is the Greek Health Record, which was developed after the Work Baby Record, and it was for older children, because the work goes to age 5 and the Greek kicks in at age 6, and it's formatted very similarly. And here's just one example of what the work record looks like, and the other is the same, where there's a different set of questions to be asked at each one of various visits. And the visits are all broken down by generally tied into when immunizations would be given. So in each visit, when you're seeing somebody anyway, it tells you the best questions and the best things to do to access a child's development and many other features of their general health. Then beyond surveillance, which is really what the work is doing, then we want to move on to screening tools. And what I've listed here are a number of screening tools that are available for us to use when we're trying to do screening. And the first one I've got up there is called the LookSee Checklist. Now, it used to be called the Nipissing Developmental Screener, the NDDS. They changed it last year. So they've changed its name to the LookSee, but it functions very much in the same way. And for those of you who aren't familiar with it, the LookSee Checklist is broken down by ages. So there is a corresponding checklist for almost every well baby visit in the province of Ontario. And the really wonderful thing about this tool is that it has been well standardized. It's very reliable. And several years ago, the government paid for this to become public domain in the province of Ontario. So if you're not familiar with it, if you go to that website address and register, you can then get access to all of the checklists. They're all free, they all can be downloadable, and they've been translated now into several languages so that you can actually download checklists to be used with the parents in different languages. And the way many people use this is that they give it to the families in the waiting room to complete before they actually visit with the healthcare provider. It's also very nicely printed in color, so it's really easy to read, and they've checked the language level to try and make it as easy for people to read as possible. The other things that are available on that page are not free. They function very well as well, so if you like the ages and stages, you can do that. And the child development inventory in the PEDS as well. But I highly recommend that if you're not using the LookSee checklist, that you do that. And this is just a little bit of information about it. Any no, so depending on the age, there could be 12, 18 questions. Any no response is something that you need to pay attention to. So if the parents have said no, the child isn't able to do something, it's really important that you get some clarification to find out what they actually mean by no. Because sometimes, for example, one of the questions asks about stacking blocks. Well, they say no, the child doesn't stack blocks. And you ask the question, well, why don't they? It's because they don't have any blocks in the house. When you get to the age about using scissors, the same thing happens. Children may not have been given access to scissors. So that doesn't mean they failed their screening. It's just that they have not had access. This is an example of what the LookSee checklist looks like, and you can see it's laid out on the right side there of what, and the parents are just simply asked to say yes or no to every question. And then the other nice thing about the LookSee is that it's actually two-sided. So when you print it, you can make 2 copies. And so, for instance, this is the 18-month one. And so the parents have answered the questions for, can their child do this or that at 18 months? And then the other half is a handout that's meant for the parents to take home with suggestions on how they can work on improving their child's development between now and the next time you would see them. And we can all give great anticipatory guidance, but it's always helpful for parents if they can have something to take home that they can read in the future. And as I've already mentioned, there are 2 categories of delay that are sometimes identified. One is the true developmental delay, and the other is the experiential, where the children just haven't had the opportunity to do that. So if they haven't had stairs, they don't have scissors, they don't have blocks, they could have an experiential delay, but you just need to encourage the parents to do activities that would allow them to develop those same skills. Now, something that comes up frequently these days to the point where my practice has shifted almost 50% to questions of autism, is specific screening tools for autism. And there's one that's readily available, which is the MChat, and that's the first one on the slide here. This is also free, and the developers of the MChat have done a lot of work in the last 10 years on trying to make it much more reliable. And it is definitely more reliable. In fact, it's functioning extremely well now. So we really are encouraging people that if there are specific questions about it, could this be autism, to use an autism-specific screening tool. The second one on the slide is called the Read-A-T, and it's had a lot of publicity, and there's been a lot of training for that in Ontario in the last 5 years. But it is not free to use, so I recommend highly that you do the MChat. And if you use the MChat, when you download the screen, it also downloads a complete set of instructions. It tells you how to do it. You don't have to go for specific training. Whereas with the Read-A-T, you actually have to have specific training. It's a whole day of training to learn how to use it. So this is what, and I don't expect you to read this, but just you to see that the screen for the MChat takes 1 page. It's very nicely laid out so that each question is in alternating shades of white or gray, so it makes it easy for people to read. And it also makes it easier to use when you're trying to follow up with the parents to say, what did they really mean by a yes or no answer? It's developed for ages 16 to 30 months. And as I said, it's free for use clinically. If you wish, you can also incorporate this into your EMR. You just have to write to the developers and ask for permission to do it, but they will allow you to do it at no cost. It's important to know when using the tool how to score it. So for the MChat, this information is all on the website, but here it is for people who want to know as well. So it divides people into 3 categories of low, medium, and high risk. And it tells you what to do with the specific scores. For medium risk, you'll see it says to administer the follow-up, and that simply means that you go through the items where the child has not passed and ask the parents exactly what they mean by that. And what you're trying to do is to find out if it's a true yes or no answer. And the other thing to note is if somebody scores in the high risk, which is a score of 8 or higher, you can skip right over the follow-up interview and just send them on for diagnostic evaluation. And the MChat is extremely good at identifying children with problems. The really nice thing about the MChat is there's a positive predictive value of 1, meaning that if the child falls in the high-risk category on the MChat, there's definitely something going on. It may not be autism spectrum disorder, but it is likely some other kind of developmental concern that requires follow-up anyway. So for a lot of reasons, it's a very useful tool. The Read-A-T that I mentioned before, as I said, it does take training, but if you want to learn how to do it, it's a very easy test to learn. It just takes a day. It takes about 10 minutes. It's similar. It looks at joint attention, how children react to emotion, and their awareness of human agency, which is really about their social connectedness. And these are 3 of the features that you see in autism spectrum disorder. So it's a very useful tool for that as well. There are some other diagnostic tools that are available as well, but I would not expect most people to learn to do this because all 4 of these things take extra training, but sometimes that extra training is available for free. So for instance, for the Childhood Autism Rating Scale has been offered as course training through the Autism Diagnostic Hub here in Ontario, and they've already had 3 or 4 workshops to try and train community-based physicians to use this tool. And there are more tools training upcoming. So that if you're interested in learning how to use the CARS, you should be able to do that relatively easily within the next year. It's a really nice tool because many of the questions that you ask as you do this are things that you're already doing as part of your history anyway. So it just allows you to take your thoughts as you're taking your history and put them in, or handle those thoughts in a more systemic way in order to come up with a diagnosis. All of these diagnostic tools are on their own are not the only thing that you need to do to make a diagnosis, but they help you form your thoughts towards making a diagnosis. And with the long wait list for assessment of autism in children right now, if any community physicians want to increase their capability to make the diagnosis on their own, they can do that by learning to use some of these tools. Personally, I find the CARS extremely helpful because it can be incorporated into your history, whereas the other tools, you actually have to take extra time. And ADOS, if you want to learn to do that and add that into your practice, and to do an ADOS or the Autism Diagnostic Observation Schedule takes about an hour minimum. I find the ADIR, the interview, is 2 hours minimum. It doesn't give you a really good idea of what's going on with the child, but it is very time consuming, and the government doesn't compensate us well to do that. It wouldn't be a complete discussion of screening for children's developmental problems if we also didn't talk about behavior problems. The Canadian Paediatric Society has again been giving us lots of tools to try and help us screen for behavior problems in young children as well. And in really young children, it's really hard to distinguish between behavior problems and developmental problems, or behavior problems that are resulting because of developmental problems. So if we can have some tools that we can use to screen this, that would be very helpful. And these are 5 questions that the Canadian Paediatric Society has suggested that you can ask parents directly to do the screening. And probably the most important question I find is the last one, is do you as parents have any concerns or any other concerns about children's behavior and social functioning? There are also some lovely tools that are available to help screen for behavior problems as well. And I've just put 2 of them up here. But if you go to the article that's referenced on the bottom of this slide, you will actually find a chart with 5 different screening tools that you can use. And I've just put 2 up here. And the reason I picked these 2 is that, again, they are free. They've been well tested, well validated, and that they, particularly the first one, has been translated into 90 different languages. So you can use it with families and get them to fill in the questionnaire. And then you might need an interpreter to communicate with the families beyond that, but at least you've got some beginning information. What I've talked about so far is about screening for children primarily of the preschool age, but we have to remember that developmental concerns sometimes don't really present until the children are school aged. And there's 2 different tools that I would recommend if you're running into children who are beginning to struggle with their academic work. And the first is this book, which is quite a few years old now. It was published by the Canadian Paediatric Society and looked at school problems in children. Now, the first part of this book has lots of information about the scientific evidence for learning disabilities and so on, and it is very out of date, so I would not recommend that part of the book now. But the middle part of the book is full of screening tools that you can do with the children in your office to give you a good idea about whether the child is having a problem with literacy or numeracy or spelling, or with their fine motor skills, that they might have developmental coordination disorder. So I'd highly recommend the book from that perspective, and it's still available. You can find it on Amazon. Another resource that's readily available that you can get in your office is published by PONDA. And for those of you who have never heard of PONDA, this is an advocacy group of physicians in Ontario that's been working to try and improve developmental services for children in the province of Ontario. So most of the developmental pediatricians in the province are part of this group, and many other pediatricians as well. And they have a website, and I put the address up there, so it's ponda.ca. And Dr. Nikki Jones Stockley, who's a developmental pediatrician in Simcoe, York, has developed an advocacy toolkit for learning disabilities. You can find it under the Documents tab on the website. And it tells you, gives lots of really helpful tips on how you can advocate with a school to try and get a child assessed for learning disabilities, and also the kinds of letters that you can write that can help the schools to be able to access resources. It also tells you a lot about the programs that are available, the evidence-based programs that are available for treating learning disabilities. So I would highly recommend that resource. Okay, so that's a quick run through about screening tools, and here's just a summary about what I think is important. If you're in primary care, please remember to do the developmental surveillance, and you do that using the work baby record, the LookSee checklist, and don't forget to ask about social emotional functioning and use some of the screening tools. At the age of 18 months, in Ontario, there is the incentive for physicians to do an enhanced well baby visit that can help you take a detailed look at development. And again, for that, you use the work baby record, the LookSee checklist, ask about social emotional functioning. And this 18-month code, so if you do the enhanced assessment at 18 months, you can bill extra. And I've just put the codes down there for family practice and pediatrics, and I verified that those codes are still in existence. They were on the latest edition of the OHIP fee schedule as of yesterday. One other code that sometimes people don't know about is that for pediatricians, if you've got a pediatric patient at developmental risk under the age of 6 and you do ongoing surveillance and document that 3 times in 12 months, there's another billing code that you can use as well. You do need to use a screening tool, but again, you can use any of those screening tools that I've mentioned previously. So that's sort of the run through on screening tools. And now I'm just going to move on and talk briefly about the red flags that may be in the children. And these are the kinds of things that sometimes the parents notice, school teachers notice, daycare teachers notice, and so on, or that you may find out as you're doing your surveillance. So this is a list of some of the red flags that we see for abnormal development. And the first few, all the way down to number 6, are the kinds of red flags that we see in somebody who's going to go on to have a diagnosis of a developmental problem relating to their motor skills. I'm going to talk a bit more about cerebral palsy screening in a moment. The next set of the red flags are for those that tend to have language disorders or autism spectrum disorder or cognitive difficulties. And so many of these red flags that are have been around for a long time are the kinds of things that show up now on the screening tools that will also help point you in the right direction towards the children who should be investigated further. And the final thing that I want to mention is the last one, which is the loss of previously acquired skills. And if that happens at any age, it's always something to pay attention to. Children they sometimes learn a skill, they can do it today, they can't do it tomorrow, but by next week they can do it. But if anybody consistently loses a skill, that is extremely important, and it tends to relate to some of those awful degenerative neurological diseases that we need to pay attention to. So if any parent ever reports loss of skills, it's something to be acted on immediately. Now, again, where can you find tools to help you know what all those red flags are? This is downloaded from the Middlesex London Health Unit, and it's part of an initiative between the health unit and many organizations in the community. And it's a red flag flow sheet. So if you don't have a copy of this, you can find it on the website, or the health unit also has it available through their resource kit for primary care providers. And it simply is really nice because for each developmental red flag that you might see, it tells you where to get service. Now, I know not all of you online today may well be from the Middlesex London Health Unit, But the red flags apply in any region of the province that we live in. What will be different is that the where to go for help will be different in each county. But I looked on some of the other health unit websites and they have something similar. So I'd suggest that you check with your local health unit to see if they have some similar tools for you. There's a big push going on now because this is a really new development in terms of which groups of children we can be more proactive with. And so we now know that for cerebral palsy, the old adage that we learned in school was that you couldn't diagnose cerebral palsy under the age of 2. And this has now been proven to be very, very incorrect. We now know with good long-term research that there are these risk factors that I've listed here that if any of those are present in the children, we need to watch them much more carefully for the development of cerebral palsy. And because of that, the American Academy for Cerebral Palsy and Developmental Medicine has developed a critical care pathway, which was published last year, to help us work through these children. So what they say is if any of these 6 things are there, then we need to put them through a standardized set of investigations so that we can accurately diagnose cerebral palsy at less than a year of age. And we know now that if we can do that, then there is treatment that is effective at improving outcomes, so you can get better long-term outcomes by starting treatment early. And the other thing that we now know is that if a child is 10 months old and we diagnose cerebral palsy, depending on what their skills are at the time, we can begin to be fairly certain about whether they're going to be ambulatory or not. And that is really important in working with families in helping them understand what the future is and helping them accept whatever the motor function is going to be for their child. So if you are presented in your office with somebody who's presenting with any of these red flags, the general approach is the history and physical that we all know about, using the screening tools, and then doing appropriate investigations. But the other thing that I really want to mention today is that while you're investigating or referring on for a consultation to look at cause, make sure you also refer them to treatment, because all of the children's treatment centers in the area that treat children with developmental problems will see them for speech therapy, physiotherapy, occupational therapy, long before they see a physician to get a specific diagnosis. And the wait lists are long, much longer than I would like them to be. So the sooner we get somebody on the wait list, the better. And then specifically, if we're dealing with cerebral palsy, we not only want to do our standard history and physical. For those people who are going to be diagnosed in cerebral palsy, there is a specific neurological examination called the HINE, which stands for the Hammersmith, is the H. It's a specific neurological physical exam, and we can all learn to do that as well. Then they also need a motor function assessment, which needs to be done by a physiotherapist and occupational therapist. And again, so that's another reason to refer for early assessment. And the DRI, for instance, the Developmental Resources for Infant in the region here, and other infant development programs around the province have all been geared up now for health therapists available to, when they get the referral for a child less than a year with motor concerns, to do these specific motor function assessments to try and help us with the early diagnosis. And finally, the third thing that we need to do is to refer the children for an MRI of their brain. So moving on now to talk finally about how we investigate the kids. The way to investigate children with developmental delays really got turned on its head in 2018 when the Canadian Paediatrics Society published this paper on the evaluation of the child with global developmental delay and intellectual disability. And it became quite controversial and still continues to be But it is out there as the position statement of what we should do. But there's some caveats to that, and I'm going to discuss those as I go along in the next few minutes. So the important thing to know about this paper is that it got used in terms of making people very zealous about doing investigations. So in the paper, when they talked about global developmental delay, they talked about this paper should apply to children with significant delay. And by that, they meant at least 2 standard deviations below the mean with standardized tests. They also wanted to be very clear that this only applies to children under the age of 5. But what it has led to is that children with language delay or with some very minor motor delays have gone through a tremendous set of investigations that this paper was never meant to be used in those specific children. So if you are going to investigate children with developmental delay or what you might suspect would go on to be diagnosed as intellectual disability when they're older, make sure that they truly fall into this significant delay category. Now, I know that all of you don't have access to standardized tests to do that, but these are the kinds of children that on your screening would be failing on everything. So they would be answering no to all of the screening questions and so on. And you get the overall gestalt, but they are very low functioning cognitively. Now, the CPS statement has this flow chart, which I'm just putting up to show you that it gets a bit complicated, and I'm going to take you through the steps. So the first box, upper middle, is this. And so what we're suggested that we do is the history and physical examination, which I've already mentioned. It's really important to check the hearing of everybody. Make sure you do something about checking their vision. You don't need to send everybody to pediatric ophthalmology. If you have an optometrist in your community that is good at assessing children, that's where you start. And only if you suspect that there's seizures should you send them for an EEG. And again, in the box that remember to refer for rehab services, that's OT, physio, and speech therapy while you wait for the investigations. The investigations that they suggest that you do in this paper for that very low functioning group was a chromosomal microarray or CGX microarray or whatever you know that as, that you test them for Fragile X, that you do the TIDE protocol tier 1 investigations, and I'll explain more about what that is in a minute. If and only if there's an abnormal neurological exam or a history of seizures, or they have a big head or a small head, do you refer for an MRI? And that if they're a girl, that you consider doing an analysis for the MECP2 gene, and MECP2 is the gene for Rett syndrome. Now, the TIDE protocol, this was developed in British Columbia, and TIDE stands for Treating Inherited Diseases Endeavor. And this was developed in British Columbia to try and give some rationale to what kinds of metabolic investigations you should do for children with developmental delay. And it was developed as a pilot and put out, and the pediatricians in British Columbia were all told that you should do tier 1 investigations in people presenting with severe delays. And then if they fail tier 1, you should do tier 2. And this is what tier 1 involved, which was a lot of investigation. And for many people, they thought it was overkill, but it was put out as a pilot and people started to do it. Now we have to remember that this was developed to try and find inherited inborn errors of metabolism, which are in very small numbers anyway. This led in British Columbia to a lot of children that would never have been investigated before going through this full set of investigations. So the people who developed the TIDE protocol were actually quite disturbed that this protocol that was still being evaluated was now being recommended for use widespread in the province of Canada, or the country of Canada. And the other thing that was difficult to implement in all the provinces is that in some provinces, some of these tests were not available to families without a charge. The authors of the original paper on how to investigate are in Quebec, and all of these things are covered. But for instance, in some of the provinces, you couldn't get an acylcarnitine profile done without a charge of about $300 to families. And in other provinces like Ontario, you could get some of the tests done if the child was sent for their blood tests to be done in the hospital. But if they went to a lab outside the hospital, they were charged for it. So it became very difficult in many places to implement the TIDE protocol. So in December last year, the people who developed the TIDE protocol published an evaluation. Did it actually work? And it turns out it doesn't. So they actually found, as you might expect when you put things into widespread use, the number of cases that you found of children with an inborn error of metabolism actually dropped from 0.91% to 0.25%. So there was a huge expense that the health system underwent to test all of these children. In British Columbia, over 5 years, they only identified 24 cases with an inborn error of metabolism using this protocol. And 20 of those 24 children actually had other red flags that would have led us pre-TIDE protocol to investigating them anyway. It was, most of them had seizures. A lot of them had regression or other neurological signs. And then there were 4 that had hypotonia and speech delay. And again, speech delay on its own, we would not have sent for metabolic investigation before. But when you combine that with hypotonia, we probably would have. So that left 4 children who had something called an X-linked creatine transporter deficiency and also speech and language delay. So really, there were a very small number of children who were detected through using the TIDE protocol, but we probably would have found them anyway if we'd been following the old guidelines for investigation. So what the developers of the TIDE protocol have done now is that they have said that you should only put the kids through the modified tier 1, which is only 4 things, all of which are covered in the province of Ontario. And so this has yet to be evaluated through the Canadian Paediatrics Society, but I suspect that we're going to very soon get a recommendation to back off from the full list of 20 investigations and just go to the 4. This is in addition to the genetic things, the microarray and the fragile X. So it would be microarray, fragile X, a modified tier 1, and possibly MRI for investigating the children with global delays. They don't want us to do these other things, in particular copper and ceruloplasmin, which we had always thought was very strange to be on there anyway, but it was there. So people now say to me, okay, so you're the expert, what do you do now? And this is what I recommend that we now do for screening, which is the history and physical exam. Ask about unusual illnesses, because that's a marker of unusual neurological function. So that's the people who've had unexplained episodes where they were vomiting and throwing up, and they did not have some kind of infectious disease. Make sure you check the family history for inborn errors and other problems. Check the newborn screening, both the hearing and the metabolic screening, because many of these inborn errors of metabolism are also caught through newborn screening, and we want to make sure the children actually had it done. Then I do a CGH microarray and fragile X, a modified tier 1, and the MRI if there are neurological signs, and then other things if I think is appropriate. So if there's anything that would be pointing me towards Rett syndrome, then I'm going to do the analysis for that. I was asked to put in a slide about barriers to change when we're thinking about developmental screening. And these are the barriers that I could think of. And one of the barriers is that we don't have the tools. Well, there are lots of free tools out there now that you can look up, and I tried to give you the websites so that you can do that. Check with your local health unit to try and find services, because if you identify a child with delay, you want to know where to send the children and their parents, because they're going to have lots of questions. Remember that there are long wait lists for assessment, and so it's really important to make the referrals early. And please, 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 now this is me putting on my hat as an administrator, don't make duplicate referrals. So don't send the referrals to several people at the same time, hoping that you'll get somebody seen quicker, because it actually slows down the process when I have to figure out that somebody else has already started investigations, and what were they and how is that so? So please try and make the most appropriate referral. And I can tell you from the flip side, as somebody who's, again, an administrator, we are trying to work to make it clear to all of you where the best place is to send the children that you're concerned about. So that's a quick overview of approaching the child with a developmental delay. And my summary comments would be to be proactive about surveillance, act immediately if you get a problem, and refer for therapy early. And again, if you access the presentation, I've put in this whole reference for the papers and things that I cited. So I hope that if you have more interest, you will look that up and read the specific details. And so that's all that I wanted to present.
Pam, that was fantastic. Thank you very much. That was tremendous and a really nice overview. So so Sarah O'Flanagan in the chat has put a link that will contain the links that Pam had. So it's a double link, I suppose. And so it's on our website for the Developmental Disabilities Program. All the links that you mentioned, Pam, are there for people if they want to look at them or find them. So we have time for questions, although I actually have no idea how much. We'll take as long as we need, I guess. So if people want to ask questions, so we'd really prefer if people use the raise hand function. That way they can be asked orally. And I believe there are at least one question already, and that's from Renato Santos. So let me actually, here it is. For some reason though, Sarah, I don't know if you have a solution to this, but all I can do is, apparently all I can do with Renata is chat, which is always a pleasure.
Hello, Dr. Nicholson.
Oh, there you go. Hi, Renata, how are you?
I'm good, how are you?
Excellent, well, welcome. So actually, if anybody, for people who have questions, if you can just introduce yourself and just briefly state what you do, just so that everybody else has a sense of who you are.
I am Renata Santos, psychometrist with the ASD team at CPRI.
All right, so go ahead, Renata. What would you like to ask?
I didn't have any questions, so I'm not sure why you called me, Dr. Nicholson.
Well, your hand was raised.
Oh, that was probably a mistake. I'm so sorry. Well,
you were just testing the system.
I know, but I can't even change it, so it's still on, I bet.
And I don't know, there's still an issue here, Sarah, because I don't know how to get somebody else. I think Jane had her hand up. And normally this is very smooth. And of course, and Jane still has her hand up, but all I can do is chat with Jane, which as with
Rob, if you just say who you'd like to ask a question, I can unmute them.
Okay, so Dr. Jane Glure, I believe, is next.
So Dr. Glure, if you unmute yourself, you can speak.
Okay, sorry. Yeah, I was glad to, don't really have a question, more a comment. Glad to see the TIDE protocol changed, because I think there was a lot of concern when it was first released as to the utility of it and the cost to families. And yeah, so I guess it's more just a comment. Thanks, Pam. That was a great talk.
Thanks, Jane. Good to talk to you.
And then earlier, Sumaya Aladamawi, I apologize if I butchered your name, had a question. Do you still have a question you want to ask, Sumaya? Sarah, can you unmute Sumaya if she has a question?
Yeah, so I have unmuted her. Once I unmute someone, they still have to unmute themselves to be able to speak. And she just put in the chat, she doesn't actually have a question.
All right, so we will, So Sarah, you have the mute all function then also?
Yes, I do.
Okay, so we'll have to figure that out. All right, other questions? So Pam, what question I had, you said that I think for primary care physicians, there is, I don't know if you used the word incentive or bonus for doing sort of a full in-depth developmental assessment, I think at 2 years of age. Is that what you said?
18 months.
18 months, right. So is there any reason that, like, is that meant for specific kids?
No,
Or
the
is it
enhanced,
to be done with everybody?
yeah, the enhanced well baby visit should be done with all children. And then there's another group of children, a subset of that group who had some early concerns, like they may have been premature or there's some other risk for their development. They can get, there's another billing code that allows people to do an assessment or extra billing every year.
Just for the benefit of a psychiatrist who doesn't do primary care, how long, like, what is the expected time frame for those enhanced well baby checks?
Well, the enhanced well baby visit is to be done at 18
So I
months.
mean, how long do they take to do?
The people who do it tell me it takes about an extra half hour.
But
And then there's,
go ahead.
and then there's the extra billing code to compensate for the time.
Okay, and then I think where am I here? I'm completely lost now. There was also another question, I think, a second ago. I apologize for our technical.
It was Dr. Goldberg had his hand up.
Yep. And so you'll unmute him.
Okay, can you hear me now?
Yep.
Okay, yeah, the question I had for Dr. Frid, and
Ben, do you want to introduce yourself first?
sorry,
Can you introduce yourself
hear
first?
him.
can I?
Introduce yourself.
Oh, Ben Goldberg, retired psychiatrist. In passing,
That is a remarkably humble description of yourself, Ben. So I guess we can, I think the London Free Press a few weeks ago described you as a super senior. Is that correct?
London Free Press did what?
They described you as a super senior.
Yes, I'm a super senior. I'm vaccinated now. Well, two things. One, I think developmental neuropsychiatry consultation borrowed from the developmental pediatric consultation, OHIP. They did the original, I think, OHIP will pay for 1.5 hours for both neurodevelopmental pediatric and psychiatric consultation. So you pioneered that. The other question I had, CPRI used to do bone age screening, and which would help in sort of diagnosing endocrine nutritional delay. And in one very famous case, CPRI, lead poisoning. And that particular lead poisoning case stayed at CPRI for about 7 years. So do you want to make some comments about skeletal age? And I understand that wrist X-ray and vertebral age are the things that are used, but we used to do wrist X-ray. I'm not sure if that's still done.
Yes, it is. So if a child was to be on your growth curve was either too big or too small, one of the things that we might do is to X-ray their wrist to look at bone age. It's not something we would do in every child with a developmental problem, but it does come up if their age or their size doesn't fit with their chronological age. Lead is also something that does come up occasionally, and I, being older, I was learned to ask that question when I was doing history. So asking about how old their house is, have they done any renovations, thinking about lead paint, asking about their wire pipes and so on. So I still do that routinely, but luckily the city has done a good job at removing all the lead pipes. but we still do something we have to think of, and it comes up now more with people who are doing renovations.
All right, Dr. McLean, you have a question. And if you could just unmute yourself now.
Okay, that works. Okay.
Yep.
Thank you, Dr. Frid. A very comprehensive overview and practical approach. And very good to hear the final results from the TIDE research that was done in terms of the yield and in terms of modification of the tier 1. I just was going to ask a very practical question for our listeners, if you could address that. Obviously, the issues about newborn screening are important, especially with the advancements in what is being screened. Just from a practical point of view, as a community physician, for community physicians, where could they practically make sure they can get those results and that that child has had that done?
I actually don't know, and that's simply because I ask people to get the results for me, and they do. Sarah, if I find that information out, could we post that next week as well?
Definitely.
Okay. I just don't have the answer off the top of my head.
Sorry
but
about that.
sure.
I was hoping you did, because I didn't have the answer at the top of my head either.
No,
but it's a good point. It's a good point. Yeah.
I'm just asking they do it. So
That's
I don't
right.
know.
Yeah. Okay.
Like
Thank
manna
you.
from heaven almost.
Thank
So and just with regards to what Sarah was saying, so the links will be on our website, but also these videos, well, the presentation are being recorded and will be up on our website, which is ddp.uwo.ca, and also on our YouTube channel.
Rob?
Yes?
Dr. Fox put in the question and answer some information about that last question.
Wow, okay.
Dr. Roach Fox did that?
I would assume that was the Dr. Fox in question. Yep.
Yes.
Okay, good. Thank you. I knew she knew the answer.
She says you call NBS Ontario and they ask for the mother's information before faxing it to you.
And Michelle McNeil says that she actually calls Ottawa directly. Who is it in Ottawa that you actually call directly? Michelle, it makes you sound very important that you can call Ottawa directly. And I cannot tell if there's an answer.
The newborn screening program, it's run at CHIO, so I imagine that's, but there's probably a website address or phone number.
Okay, thank you.
Okay, well, I'll look it up and we'll post it next week.
Okay, great. And so we'll take one other question and then we will move on. Dr. Paver, you had a question a minute ago. Is that still the case? If you just unmute yourself, you're up.
So medical record where the child has been born will always get a hard copy. And if you're asking for birth records, you can do 2-for-1 deal and you'll get the results.
Dr. Paver, do you mean medical records here at the hospital?
Any hospital where the baby was born.
Just out of curiosity, what happens if they're born outside of the hospital?
Any place where the newborn has been born, be it a home delivery or a midwife delivery or on the hospitals outside of our local hospital, they'll always have a hard copy given to them.
That's great. Thank you very much, Dr. Paver. That's really important information.